Hill, and I am going to show you how to perform a postpartum assessment on a new mother. There is a mnemonic that we use to help us perform a postpartum assessment, and that mnemonic is Bubble He, BUBBLEHE. So we're going to do a Bubble He assessment. The first thing that I want you to know about the Bubble He assessment is that this is only a focused assessment. This assessment does not replace your full head-to-toe assessment on a postpartum mom. The Bubble He assessment is an extra added focused assessment on top of your head-to-toe that you would normally do on a patient that you are taking care of. So we have Lucinda here, and she is our postpartum mom who has just given birth, and we are going to go through the Bubble He assessment just as if we were in an acute care setting. So the first B in Bubble He stands for breasts. As you all know, moms who have delivered babies will end up making milk in some form. Some of those moms may breastfeed and some of those moms may not. But one part of the assessment we want to do for those moms is to look at their breasts, because that's a major part of what their hormones are doing at this time. So we're going to assess both breasts. We will, of course, identify our patient, provide privacy, and you're going to want to assess the breasts bilaterally. We are looking at mom's breasts for any signs of lumps, any bumps, any spots of redness or tenderness. We pay very close attention to the nipple and the areola, particularly if they are a breastfeeding mom. So as you're assessing the breast, I'm going to try to lean over and do it on this side so you can see. We're going to start from the axilla, and we're going to just palpate down after we've also inspected to look for signs of redness or engorgement, areas of swelling. And then we're going to inspect the nipple for any cracks or fissures. Those types of issues on the nipple or the breast could put the mom at a greater risk for infection. So if the mom is breastfeeding and the baby is not latching well, sometimes that will cause blisters, open areas of soreness on the breasts. And that's something that you want to identify as a nurse for that patient, because we have medications that we can give to those moms. We can also help with breastfeeding education. We could help her the next time she put the baby on, latched the baby to feed to make sure she was doing it correctly. There might also be newborn assessment that we would want to do if we noticed any of those issues going on with the breast. So sometimes babies who have tongue ties cannot latch properly. It appears as if they are, but their suck reflex is just a little different. The way that they suck can cause problems. So a really important area to do your assessment on. Now, the other thing that we are palpating for whenever we palpate a breast is whether or not that breast is soft, filling, or firm. So moms generally get their milk in at about 3 days postpartum. So most of the time when you see moms in an acute care setting right after delivery, what you're going to palpate is a soft breast. But there will be times when you palpate a breast that's filling And as milk begins to fill into the breast postpartum, it starts up in the axilla and fills this way, sort of down into the breast like that. So when you palpate, that's why we start up in the axilla, because that's where things are going to start to get firm when they start getting milk. Another thing that you want to look for are any types of discharge from the nipple. Moms will have colostrum that you might be able to actually squeeze out. Most mothers will have that. It's a sort of yellow, clear discharge, and it is the first stage of breast milk, and that's totally normal. But if you have a mom who has some cracks or some fissures in their nipples, it's possible that those could be infected, and she could be having some type of discharge that is pussy or purulent, or something that is not normal, bloody discharge. Those things would definitely need some further intervention from you. So that's breast. We provide our mom some privacy, and then we would move down to the U in bubble he. And U stands for uterus. So the one thing that we are mainly concerned about with the uterus in a postpartum mom is, number one, is it firm or is it boggy? Boggy means soft. And number two, where is it placed in the abdomen? And to be able to assess that, you have to be able to palpate the uterus. And it is sometimes a little difficult to feel, and you really do have to dig to find that. But I want to talk about why firmness and bogginess are so important whenever you're assessing a uterus. When the uterus is firm, that means it is clamped down. The uterus is a smooth muscle, so it has the ability to contract and stay contracted. As long as the uterus is contracted and it's nice and firm, that mother is not going to bleed very much. It's going to help control the bleeding that she is having after birth. However, if the uterus does not do its job and it does not harden up and clamp down to help sort of close off those blood vessels in there, and it's boggy, the mom will have a lot of bleeding. And that is one thing that you want to catch, and catch quickly, because moms can have a hemorrhage in a very short period of time, which can cause severe problems. So, when you do your uterine assessment, we call it a fundal rub. The top portion of your uterus is called the fundus, and that is what we are trying to feel for whenever we do a uterine assessment. You always, number one, wear gloves. I just can't get to mine right now. They're on the other side of the bed. You will always support the lower segment of the uterus with your hand. So as you can see, I kind of have my hand, my thumb sticking out and the rest of my fingers to the other side. I'm going to use this portion of my hand to support the lower segment of the uterus. So I'm going to place it right here on mom's lower abdomen, sort of directly above her pelvis. With my other hand, my dominant hand, I'm going to start at the umbilicus. That is always your reference point whenever we're doing assessment on a postpartum mom, because directly after delivery, the fundus should be at the umbilicus. So at U is how we would chart that. The fundus will decrease, or the uterus will decrease in size day by day until it is back to its original state or original size. It typically takes a uterus about 6 weeks after delivery to get down to its normal size. But day by day, you will find that a uterus, a normal one, will decrease in size by about 1 to 2 finger breadths every day. So a finger breadth would just be your finger or 2 fingers. So below the uterus, 1 to 2 fingers is where it should be 1 day postpartum, 2 to 4 where it should be 2 days postpartum, and so forth until you probably can't feel it anymore because it's back into the pelvis. So let's talk about, let's get back to how we're going to do this fundal rub. We're going to support the lower segment of the uterus with our non-dominant hand. There's a reason for this, because when we start to rub, we do not want to stretch the ligaments that hold the uterus in place. We do not want to push the uterus out through the vagina whenever we're doing this. So it's very important to support that lower segment. We're going to take our dominant hand and we're going to place it at the umbilicus, and you can see I'm using the side of my hand. So you can also use your fingertips and go this way. If you don't have very long nails, that would be uncomfortable if you did. But we're going to go straight back. We're going to press down. We're going to go straight back and down to feel the top of that fundus. If it's firm, that's perfectly fine, and we don't need to do anything else except for note the location of where you were able to palpate the top of the fundus. This lady's fundus is nice and firm. It's about U minus 1, so 1 finger breadth below the umbilicus, and she's good. However, if she had a boggy uterus, we would continue to massage. We would do a fundal massage until that uterus started to firm up, and at the same time we would note what type of lochia we were able to express from the vagina, meaning what type of bleeding. All right, so that is uterine assessment. We talked about placement as far as where the uterus should be directly after delivery and how it decreases in size. When we move to the next B, we talk about bladder, and the B after that is bowel. So we're going to assess bowels and bladder. Is the bladder distended? And this is an important thing to note because it will push your uterus up and out of alignment if your bladder is distended or full. So is that uterus in the midline of mom's belly when you assess it, or has it deviated to one side of the abdomen or another? If the bladder is full of urine, it pushes the uterus up into the abdomen and over to one side, and you can tell that. So it's always a good idea to ask the mom if she has voided before you start to do this assessment, so that your uterus will be in the place that it should be with the bladder empty. Now, if you assess that the uterus is over to one side or the other, it's a little higher in placement than where you expect it to be, you would just ask that mom when was the last time she voided, and depending on what she tells you, you might have her get up and try to void again and then reassess the uterus and the bladder. This is something that you really can do at the same time as you're placing your hand on the lower segment of the uterus. You can palpate to see if the bladder is full at the same time you're attempting to do your fundal rub. So these two can sort of be done at the same time. As far as bowels are concerned, we want to ask mom when she last had a bowel movement. It is very common for postpartum mothers to be constipated or to not want to go to the bathroom after delivery, particularly if they have had a C-section. Because then they're not moving very much, right? They're not up and as active as they would be if they had not had a major surgery. If they've had an episiotomy, or if they have hemorrhoids, which are common things that happen during labor and delivery or pregnancy. Hemorrhoids happen commonly in pregnancy anyway. If moms have either of those two issues, it makes it very difficult sometimes for them to have a bowel movement. It's uncomfortable, and so they become more and more constipated. So that's one reason why we pay close attention to bowels. We don't want moms becoming backed up, and we want to get them some medication like Colace, some type of stool softener, milk of magnesia, and Colace is what we typically give, and we want to be able to do that to provide mom with as much comfort as possible. All right, so we've been through the B, the U, the B, and the B: breasts, uterus, bladder, and bowel. The L in bubble he stands for lochia. Lochia is the term that we give to bleeding, the bleeding that happens post-delivery. There are 3 types of lochia. We have lochia rubra, lochia serosa, and lochia alba. And I have examples of those that I am going to show you once we do our lochia assessment on Miss Lucina. Lochia rubra is the bright red bleeding that moms have immediately after delivery. It typically lasts between 1 and 3 days. Every mom is different, so there will be a different time period for everybody, but typically you see that bright red bleeding 1 to 3 days after delivery. Lochia serosa, a very easy way for me to describe this is like a serosanguinous drainage almost. It's more of a pinkish bloody discharge that's mixed in with a little bit of clear yellowish discharge as well, so it's more pink than bright red. And then lochia alba is just a white almost a discharge that you get closer to the time that your uterus is beginning to go down, get back to its normal size. So for Miss Lucina, since she's just delivered, we would expect to find lochia rubra on her peri pad, and what we want to see is a small amount of lochia, small to moderate. A large amount of lochia could indicate problems that possibly her uterus is not firmed up well, that it's boggy, we need to rub. It could indicate also other postpartum complications or complications that happened during delivery. We do not want to see a steady trickle of lochia or bleeding coming from the mom's vagina. We don't want to see spurts of blood coming out. We do not want to see large clots. You may find in postpartum moms, particularly ones who you are doing morning assessments on, who have been in bed lying down through the night, you may find some clots that happen for those moms just because they've been lying down all night, and they may have some blood that is pooled in the vagina and clotted up through the night because they haven't been getting up and moving around. But otherwise, we should not be able to express several clots at one time. You shouldn't be seeing moms consistently passing clots that are the size of a golf ball. You may see a few here or there, but they should be very sporadic if they have them at all, and they should be of minimal size. So we would uncover mom, and I'm going to uncover Lucina all the way down so hopefully you can see a little better on the video. If she had any family members in the room, you would also want to ask if these people could step out while you do this part of the assessment, because it is a very intimate type assessment, and you want to be sure she's totally comfortable with people who are in the room. So the best way to look and see what's going on down here is to have your mom to frog leg as best you can, because you want to be able to visualize it all. we're looking to see what type of bleeding is on her peri pad. This mom does not have on a peri pad, but she has a blue chucks that's underneath here. And unfortunately, I don't think I can lift her up to show you, but she has a spot on her peri pad that is bright red. I'm going to try to turn her so you can see. Come on, Miss Lucinda. Okay, so she has of course I would be wearing gloves if I were doing this in the hospital, but you can see she has a spot on this peri pad that has, I don't know how long it's been here, but if this had been, you know, what she's bled out in 30 minutes, I'd call it a moderate amount. If this came out in 1 minute, that would be a little different. I'd be watching this patient much closer. If she had this whole entire spot overnight and this had not been changed since the day before, then I would call it a small amount. So always remember that when you're assessing lochia, we're also thinking about time frame. How long has she had the peri pad or the chucks pad on? And well, you know, what type of situation are you in? But we definitely have some lochia rubra for Lucinda. All right, so that takes care of our L in bubble heat. The E stands for episiotomy / laceration. So an episiotomy is a procedure that happens during delivery if the physician or the healthcare provider believes that the mom needs a little more room in the perineum for the baby to be expelled. So they will use a pair of scissors and they will cut the perineum in whatever direction they decide is the best. And after delivery is over, the healthcare provider will stitch that up. Episiotomies can happen straight down the middle of the perineum. So that's a midline episiotomy. They can also happen, if this is the perineum, they can happen this way, which would be midline. They can also happen sort of off to the side adjacent to midline, so kind of this way to either side. That would be called a mediolateral episiotomy. Typically you get that information in report, but you can also see it in the mom and you can see the stitches. It is very difficult to visualize a perineum on a mom depending on what her size is and what her labia is like. How swollen is it after delivery? Is there any places that are inflamed? Are they red? Typically moms are swollen after delivery down there. So you may have to part the labia to actually see the perineum to assess for an episiotomy. Now a laceration on the other hand does not, that happens naturally during delivery. So that would be a tear. A laceration is a tear, whereas an episiotomy is actually a procedure performed by the healthcare provider. A laceration can be corrected with stitches, but not always. It depends on how bad it is, how bad it's bleeding. I have seen moms that have had lacerations that were not very bad and the physician let those heal on their own. So it just depends on what you got going on. The best way to visualize an episiotomy or a laceration and the perineum in general and get a good look is to do what I said earlier, is to have the mom frog leg. If she's a smaller patient, you should be able to part the labia and look in this frog leg position and see what you need to see. Now, That doesn't work for everybody. If you have a larger patient, you're going to need to roll the mom away from you and part her cheeks so that you can take a look that way. So for the sake of this video, I'm going to roll her towards me so that you can see. All right, come on, Miss Luciana. Okay. So I would, if I were assessing this mom, I would use my gloved hands. I would part her cheeks. I would look from the perineum back to the rectum. I'd be looking for the episiotomy. If she had an episiotomy or a laceration, that had been corrected, meaning it had stitches. I would be looking to see, is it intact or is it together? Are there any hematomas starting to form? Is there any redness? Is there any edema? Any ecchymosis around the site? And is it approximated or together? Okay. Your acronym for assessing episiotomies and lacerations is REEDA, R-E-E-D-A. That is in your book. So at the same time, we're also looking for hemorrhoids. Remember, I talked about bowels and how hemorrhoids can affect moms taking bowel movements after delivery, and that we want to help them out with that if they have any of these issues. So also look and visualize for any hemorrhoids that mom might have. All right, so that's the E in bubble. So we've been through B, U, B, B, L, E, breasts, uterus, bowel, bladder, excuse me, lochia, and episiotomy. We have 2 letters left, H and E for he. The H is Hohmann's sign. Now, Hohmann's sign is not something that you have been taught in for your head-to-toe assessment. And the reason that we don't typically teach it anymore is because it is not an evidence-based assessment practice any longer. However, you will find Hohmann's sign on every charting system that you go to at this point in time on a mother-baby unit. It is something that we use and we chart on every shift or every assessment. So I'm going to show it to you here, but I want to point out that this is no longer an evidence-based assessment, and you'll understand why. So Hohmann's sign is supposed to be able to tell us from an assessment standpoint whether or not a patient has a DVT or a deep vein thrombosis. Now we know from learning about DVTs earlier in your program that what you're going to see if a patient has a DVT is redness, swelling in whatever area that thrombosis is at, and your patient may complain of pain. So Hohmann's sign is just an assessment that the nurse can do to help possibly indicate if this patient has DVT or something that's starting to form. And the way that we do this is by taking the toes of the patient's foot and pulling those toes towards the mom's face. So basically we are stretching the calf muscle in essence. And if the patient has a DVT, the theory is that they would have some pain whenever we did this. Like I said, not evidence-based. Your Hohmann's sign is charted as either positive or negative. Positive means that the patient has had pain whenever you pulled their toes towards their face. A negative Hohmann's sign is if they don't have any pain. Now, always couple that assessment with your actual inspection of their skin. So is there redness? Is the patient having pain otherwise? Is there a red streak up their leg? The reason why this is included in the focused assessment for a postpartum mom is because there are a lot of hematological changes that happen during pregnancy, and the ability to get blood clots is one thing that women who are pregnant and postpartum are at a very high risk for. So this is something that we really focus our assessment on. The last part of the Bubble He assessment, the last E, stands for emotions or emotional state. We are constantly assessing the emotions and the emotional state of our new moms. We want to know how they're bonding with their newborns. Are they bonding, or are they not doing a very good job of bonding? Do they seem to be a little bluesy? Meaning they seem to be a little sad, they're crying for no reason. Do they exhibit symptoms of depression, anxiety? Are they overwhelmed? All of those things are assessment data that we want to collect so that we can, number one, tailor our education to mom, and number two, intervene for any sort of problematic areas such as depression, or a mom who's not bonding well with her newborn. There are specific interventions that we would want to implement for patients who are exhibiting different types of emotions or emotional state. So that's our last E. Quickly, before I jump off of here, I'm going to point out one more assessment piece that is it is not part of the Bubble He assessment, but it is an assessment that is pretty standard in labor and delivery and in the postpartum world, particularly for mothers who have hypertensive disorders of pregnancy. They have pregnancy-induced hypertension, or they have some issues surrounding blood pressure. And one assessment thing that we do for those types of moms is something called clonus. Moms who have very high blood pressure or who are very neurologically sensitive because of high blood pressure will exhibit something called clonus. And to assess clonus, you have a mom relax her leg. So I'm holding Miss Lucinda's leg in my arm and she's totally relaxed. And we take our hand and sort of pop their foot back towards their face, like that. If Miss Lucinda had clonus, her foot would beat back at me. So if I popped it this way towards her nose, towards her face, her foot would reflex back to me, like that. And it would be an involuntary reflex. We measure clonus in beats. So if there is one pop back, that's 1 beat of clonus. If there are 2, that's 2 beats. 3, it's 3 beats. The more beats of clonus that you have, the worse it indicates your condition is. And that is how we chart it. 1, 2, 3 beats. Or no beats. So I quickly wanted to show you that. It is not part of the Bubble He assessment per se, but it is an assessment that you will see a lot of in labor and delivery and in postpartum, particularly for moms who have blood pressure issues. Thank you for watching this video. I hope you were able to see well enough. And of course, you always have your book so that you can read through this as well. Thanks for watching. Oh, I'm going to show you the pads of Loki. I forgot about those. Hold on. Okay, I'm not sure if you guys can see this very well or not. I'm going to hold it up. All right, so we have some different types of lochia that Miss Alton has made us here, and I'm going to point out what is what. So this first one, oh, not that one, this one right here, that is Lochia rubra. This would be a large amount. The pad is pretty saturated there, but you can see you've got some darker red. It's really bright red. This one in the middle, right here, this is Lochia serosa. You may find that the Lochia serosa you see in the hospital is a little lighter than that. This is dried, so it has turned a little darker than it was initially. So again, we're looking for something that is sort of pinkish in color, comparative to serous sanguinis drainage. This is Lochia alba, and again, you can sort of barely see that. It's got a little bit of a yellow tint to it, but mostly white. All right, those are our examples of Lochia. Thanks for watching.